the end, and I know people will be trickling in still. And I just want to welcome everyone to today and the hosting the Health Services and Policy Research Institute, the last research rounds of the 2020. So we're looking forward to a brand new year. For those of you who don't know me, my name is Catherine Donnelly. I'm the director of the Institute, and I'm thrilled to have two extremely esteemed presenters here today. For those of you who would like to get on the listserv, we host these on a monthly basis. So I've put in the chat Sherry Scanlon's email, as well as a link to the YouTube channel. So after each talk, these are recorded and put on the YouTube for you to take a look at and share as well. So I'm going to start by introducing both of these speakers today, and I could spend the whole hour talking about all of the things they've accomplished. So Doctors Duncan Sinclair and Don Drummond. So Don Drummond is a Stauffer Dunning Fellow and an adjunct professor at the School of Policy Studies here at Queen's. He has a very long history, 23 years with Finance Canada, working in economic analysis, forecasting, fiscal policy, and tax policy. Has held multiple senior positions, and most notably, and you will recognize him, he was chair of the Commission of the Reforms of Ontario Public Services, known as the Drummond Report. Duncan Sinclair is a professor emeritus at Queen's in physiology and fellow of the School of Policy Studies at Queen's University. He's a former vice principal and past dean of the Faculty of Health Sciences here at Queen's. He served in many, many leadership positions and chaired a number of commissions himself. He sat on and was chair of the Health Services Restructuring Committee. He is widely recognized for his leadership in healthcare reform, receiving many honors, most notably the Order of Canada and the Canadian Medical Hall of Fame. So I pass it over to both of you to talk to us about aging today. And if the two of you cannot solve all problems, we don't know what we're going to do. So thank you very much today. If people have comments in the chat, I'll be monitoring those as well.
Okay, thanks very much, Catherine. I'm going to lead off and then turn it over to Duncan. As I'm leading off, I'm going to give you a little bit of an introduction to the report because this is a new venture for us. We have collaborated along with other people in Queen's Health Policy Council on very short pieces, the traditional 2020 circa blogs and et cetera, but we've never done an extended research piece like this. One of the difficulties of doing research like this from the School of Policy Studies is it's difficult to find students that you can exploit. They as a one-year master's program, and they're typically taking 5 courses at any given time, and they just don't have any additional time for this. And then in the summer, they're off to co-ops, and then they're off usually to full-time job, although that's getting tougher. So obviously with COVID coming along right about the time that they were lining up spring and summer jobs, a lot of them had their employment prospects dislocated. And we did manage to get a little pot of money from the university to hire some research assistants, and that gave us the green light to do something we'd want to be doing for quite some time. And it was interesting, just another piece of history. It started off as care of the elderly, and we're a bit taken to task from those much more expert in the subject of that. So that wasn't a good framework. That presented the elderly as needed to be cared for, and the theme really should be aging well, and hence the subject of this. So we did this with an enormous help for research assistant, and particularly one in particular, Rebecca Burgeon, who interestingly has now gone on to work in the Department of Finances. And if the federal government were so likely to solve this, is actually in the branch that would be involved. So that was kind of a nice strategy that played out of this. Of course, if you think back when we started this in early spring, it was right at the rage of the COVID-19 affecting the long-term care homes, and we were seeing the creation of a lot of commissions, advisory panels, and the like pretty much across the country. We have a formal commission in Ontario, but there's something pretty similar to that in pretty much every jurisdiction. And we thought that in all likelihood, they will focus on the safety-related issues. Why do there so many deaths? How do you prevent a situation like that going forward? And we thought, well, if we're going to peer into long-term care and aging, we really need to put it in a broader context. And first, as with most things, hopefully in public policy, to try to deliver what people want. I don't think there's too many people that stick their hand up and say, I would like to go to long-term care. They tend to get placed in long-term care because there doesn't seem to be other alternatives for them. And we also need to put it in the context of the demographics. So I think we're now all fairly familiar with the basic numbers on the demographics that when Medicare was created in the 50s and 60s, seniors were less than 8% of the population and didn't tend to stay seniors very long because the longevity back in 1960 was only 71 years. And I think we all know that we've crossed the 1/6 marker. We're about 17% seniors, and most are pretty familiar by the 2030s, and by the time we reach 2040, it will be about a quarter of the population. So that means in 20 years, another 4.2 million seniors. So we put that in the context of history. If you could put it so crudely, we absorbed 4.2 million seniors over the last 40 years. This time around, we have just slightly more than 20 years to absorb the same number again. But that kind of misses the point. That's the part that people are familiar with. The part that people aren't as familiar with is they don't think about the mathematics of the baby boom generation. It's not just that they're turning senior, it's that they're going to be getting up into the elderly ranks. And just the simple math of it, the people who were born in the 50s and the late 40s and bulk of the baby boomers in the 50s, they're going to be turning into the 80s and not too long. And not too much happens health-wise, fortunately for me, I hope, or in terms of care in the 65 to 75 range, and it notches up quite substantially at 75 and then notches up again quite substantially after 85. And of course, that's the area that the bulk of that senior population is ending. And we thought, well, it would really be a shame to have all this attention on long-term care and aging without recognizing that demographic. Duncan and I were discussing one of the benefits of doing a report like this and doing a number of presentations like this is, and a lot of media interviews and receiving an awful lot of emails from people, more so than I think we've ever done on anything we got before, and what's on people's mind. And one of the common questions we get is, if this is so predictable and demographics are pretty predictable, why are we in this situation? Why is not anything being done about it? And the best answer we can come up with a certain policy stasis that if you were sitting here in the 1950s and 60s and trying to figure out what you needed in terms of healthcare, you would have probably landed on acute care because you had a young population. You didn't tend to have morbidities and multiple morbidities and chronic diseases and the like. You had broken legs and the like, and we created something to do that. And I think if you look at all policy areas, even if the conditions shift relatively dramatically, policy tends to go in incrementalism, particularly if you don't have a single natural leader in it and you have various different stakeholders that are fairly loosely coordinated. It's also a case, I think, where you get caught into the political cycle determines the policy cycle. So if you're a politician, your focus is pretty uniquely on the next 1 to 4 years because your be all and end all is to get reelected. And that doesn't bode well for dealing with problems that may be 10 and 20 years out in the future and may actually incur cost right today. And I was told by somebody just last week that a major concern that the premier of this province where I'm sitting in is very concerned about this, that over his watch, or at least the remaining of his term, there may be some substantial costs connected with dealing with problems that the payoff may not be apparent until after the election. So that's a kind of thinking that stands in the way. So we started off with doing a little bit of the demographic projections, and we're particularly interested in if we continued the same protocols as of per day, in particular, if the same percentage of every 80-year-old ends up in long-term care, the same percentage of every 85-year-old, et cetera, ends up in long-term care, how many long-term care beds will we need by 2041? So looking out, just pick these odd years because they match up with the census data. And we figured you'd need another 250 to 300,000 beds. So we have roughly 250,000 beds today. So it's more than a doubling of the number of beds. But there's two caveats around that as well. First of all, that is a net increase. If you take any beds out of commission, you have to replace those before you even start to make a dent of the 250 to 300,000. So if you look, for example, Ontario's a number of years in their pledge of creating 15,000 beds, and I think if we did the proper counting, they're probably a net negative so far because of the ward beds taken out of the hospitals and other things. And I think we can be fairly certain that as the commission's reports and across the country, the various advisory groups come in, if their recommendations are taken, a lot of the existing beds will be taken out of commission. They'll just be viewed that it won't be economically to make them up to a safety standard. So we're thinking on a gross basis, you probably need a lot more than 250 to 300,000. Plus, if you were to tackle the existing wait list, you would need a lot more than that. So in Ontario, typically you've got between 25 and 40,000 people waiting to get in a long-term care bed, and you can multiply that across the country. So you could probably be talking more like 350, 400,000 beds, almost a tripling for what we've got. And believe me, nobody is planning on doing anything remotely like that. I don't think it will happen. We would argue, we kind of hope in a way it doesn't happen if the alternative come into place. If the alternatives don't come into place and the long-term care beds don't come into place, then we're deeply in trouble. Then we did what very few Canadians actually do. We looked around the world and just saw what others are doing. And in part, the answer to this question of why we haven't done anything about this in Canada is because Canadians are trained instinctively from birth to compare themselves uniquely to the United States. And the United States doesn't do much in this aging space of any interest, so Canadians have never felt any inspiration or any competition to do anything. But lo and behold, other countries do quite a bit. So we're in a perverse and ironic position where we actually underspend substantially on long-term care relative to the average of developed countries, but we underspend on home care even more dramatically. So we're off the scale on long-term and underspending. We're even more on the scale on home care, meaning the ratio of what we spend on long-term care versus home care is one of the highest in the world. So we spend 1.3% of our gross domestic product on long-term care. The OECD average is 1.8. So we might think we spend a lot, but we don't. One of the biggest differences, we have about 1/3 fewer workers per resident of long-term care. We tend to pay them less, they're less qualified. And of course, we have inferior infrastructure and safety protocols. On the home care front, though, we only spend 0.2%. So it actually stands out even as a greater anomaly. There's only of the 35 members of the Organization of Economic Cooperation, there is only one country that spends as little, and it's actually the poorest one in the entire group. So we're not in very good company. And then when you put that sort of numerator and denominator together to get the quotient, we spend $6 on long-term care for every dollar of home care. Most of the Northern European countries spend equally on the two. And Denmark, which probably by no accident tends to score highest on life satisfaction of seniors, actually spends more in home care than they do on long-term care. And famously passed legislation in 1987, making it quote unquote illegal to build any more long-term care beds. And since they passed that legislation, they've actually taken 30% of the number of beds out of commission. It's a silly piece of legislation in a way, because you're just legislating a piece of discipline on yourself, but obviously it's worked and it forced them to build a reasonable long-term care. If we don't want to end up in that world, how could I forget? Being the economist and being known as the bean counter, I forgot to count the beans. So we spend 1.3% of GDP on long-term care right now. My guess is that will increase by 1/3 as the recommendations flow on and improving long-term care infrastructure. And then another 1/3 by more workers, better paid workers, better trained workers. So we'll go from 1.3 to 2.1% of GDP in fairly short order, I think, within the next couple of years. And that'll be without expanding any bed capacity. And that'll take us from well below the OECD average to a little bit above the OECD average. So really nothing remarkable in that at all. But then if we double the number of beds, we'll go from 2.1% of GDP up to 4.2% of GDP. So putting all the three factors together, we will in the next 2 decades, if we follow the existing protocols, go from about 1.3% of our gross domestic product on long-term care up to 4.2%. And of course, that begs the question of who will pay. And I wish I actually could have $1 for every person who said to me, well, the government needs to pay for it because then it'll be free. And I constantly have to remind them that the government hasn't yet invented a tree that's growing the money. And indeed, even if the Bank of Canada at the moment is buying up their bonds, that's just a temporary arrangement. And all they do is collect the money from us and direct it in some particular place. So whether it's government or it's private industry, whether it's federal government or the provincial, Canadians will pay for this. There'll be an enormous increase in the amount of money that's paid. And the only thing really is to debate about it is the incidence. If it's a very large monthly charge for residents, then seniors and those connected with them will pay the bulk. And if it's done through taxes, then it'll be spread more evenly across the working age population. And as if governments are wont today to borrow it instead of putting on taxpayers and its future taxpayers, i.e. all of it will be dumped on the seniors, the younger people, along with all the other debt. The final two things I will address is if you don't want to end up in that world, and I think we don't want to end up in that world with so many people ending up in long-term care, you need to be worried about conditions like frailty and dementia, because many people in long-term care have one or both of those conditions, and also many of the elderly with those conditions end up in long-term care. And there I was very encouraged by the expert advisory group we had, which presented to me as a layperson this very credible evidence that there are things that can be done in the extreme to prevent these problems, or even if not to prevent them, to defer them and lessen the incidence. There's an interesting moment. We made a presentation to Ontario's Long-Term Care Commission, and I was at one point getting a sense that they were skeptical a bit and thinking there was an inevitability that a large number of elderly would end up in long-term care. And I presented a statistic I think is quite stark, that the average duration of somebody in long-term care is only 2.5 years. So even if all you did is defer that by 6 months to allow them some more satisfactory living arrangement prior to that, and push that out by 6 months, there goes 20% of all the long-term care beds that are in demand. So you don't need to have a phenomenal outcome to have a significant improvement in that. I did a quick check, because when we were doing our projections and trying to estimate the percentage of people who would end up with frailty and dementia, I was interested to see if that too is a stable relationship by age. And it turns out it has been. But I worry, and I again emphasize, from my background, I'm not medical background whatsoever, but for my laypersons, one thing that does concern me is some of the lifestyle changes we are seeing, and whether those will be predictors of some increased problems. One that really leaped out to me was a startling reduction on physical activity of women in the near senior group, the 45 to 65 age group, that's happened over the last couple of decades. And given the fairly high rate of dementia and frailty for women, that can't bode well, changes in diet and the like. So maybe if anything, these demands left in the current protocols would need to get even worse than there. So Duncan and I have done a couple of presentations, and it's kind of our version of the bad cop, good cop. I get the pleasure of laying out all the problems and depressing you, and then I turn to Duncan for how it might be solved. Over to you, Duncan.
Well, thanks, Don. I've told a story several times in these interviews. Forgive me for those of you who've heard it before. I ran into an old friend. She's a widow of a person where in their family money is not really an issue. And we were at a drugstore, both of us picking up refills of our prescriptions, and got talking, and she told me about having given up her house and having moved into a retirement residence. And as I said, Allison, how are you doing? And she said, Dunk, I'm warm, I'm dry, the meals are passable, I can still get out to play bridge with my cronies, and I'm okay where I am, but it's not home. And to age well, people have to believe that where they are is home. It's a really kind of happiness we need to be measuring, not necessarily health. Many people with many infirmities, if you ask them, how are you? Which is the first thing you normally say to somebody, they say, I'm fine, I'm well. And they are, they feel well. And that's what needs to be done to help people to age well. And so the study that Don and I are doing is, he said, the good the good cop side of this is what do we need to do to make it better? I don't believe that currently people in long-term care homes on the whole are very happy. In fact, my old neighbor lived in one very nice home here in Kingston. And before COVID, I was able to visit her quite frequently. And she was okay, but she was not happy. It wasn't home. And those other people to whom I talked in there were of the same part. So as Don has said, thinking about the onset of those chronic diseases of old age, Don describes himself as the archetypical baby boomer. I'm more in the nature of the archetypical old folk right now. I'm on the north side of the 80th decile, and happily I'm able to live entirely on my own. But as I think about my fellow residents out here in the boonies north of Kingston, I know several of them who have had to leave their homes because the delivery of the support services they need, not many support services, the delivery to them is quite impossible because all of our resources are going into essentially residential-based long-term care and not into home and community care. So one would like to think that in our democracy, one of the issues that would be very much on the mind of our elected governments, provincial, territorial, and mainly, as Donna said, the ones that dropped the ball most resoundingly, but the federal government can't get off the hook on this either. Everything that should be on their minds, front of mind, is how to meet the needs of the population, of which seniors become an increasing component. And I don't think they're doing that very well. So just to follow up on Don's question, well, the most frequently asked question, who dropped the ball? Basically, it's the same governments that have had electoral considerations, I think, have given electoral considerations much higher priority than they have given to meeting the needs of their constituencies. And the part of the objective of this report is to point out what the needs of those constituencies really are and to give more priority to doing that. I kind of dislike the word care. Now, there's nothing wrong. People will need it. It's one of the 4 basic needs that elderly people, many people, will need. But it is not inclusive of the concept of support rather than care per se. As one of the members, and Catherine, you remember being one of our advisors on this, said, when you are in care, you lose the freedom to make your own choices, and there's no joy in that. And so I really worry about our using these 3 initials, LTC. I would really describe it as LTS, long-term support. And in fact, those are the words that are used in Denmark and several other places, where the degree of satisfaction is very high. John Muscadera, the scientific officer who leads the Canadian Frailty Network, he and his colleagues spent some time in Denmark this summer. And it's very clear that the community-based approach to looking after people who will need long-term support and including healthcare, but primarily they will need support for their personal day-to-day activities. They need social support, they need the lifestyle support, and they need all of those three in housing that's appropriate for their particular needs. The accommodation we have here in Canada in long-term care is almost a one-way street. Once admitted, as Don said, the stay is 2.5 years, but after 2.5 years, it's not a return to their homes. It's to another kind of institution where they'd prefer not to be. Personally, I'm not looking forward to going to Cataraqui Cemetery. It should be kind of lonely out there. So, but we'll see. Anyway, the objective is really that we were trying to is to ensure that governments paid attention, and happily enough people have read this report, and enough media have contacted us that I think we have, well, I'm encouraged to think we might make a difference. So that's really good. The shifting the emphasis from the housing priority to a broader priority of these other needs, and welding together those 4 needs in the diagram that we have in the report. I think pretty simple concept. It's complex in terms of who's responsible for actually doing it, but the actual interrelationship of those 4 things it's pretty simple, and in fact can be done in most communities with a little more support than they have at the moment. I read a very interesting report in the Guardian newspaper from Britain some little while ago about a wonderful community in Somerset, in a little town called Frail, in which a physician being very unhappy with the incidence of people going directly to the emergency rooms of the hospitals there, did an analysis of why they were going there, and persuaded the community of Frail to set up a number of what they called community connectors, who put together a list of the availability of services in the community, and brought them to the attention of elderly people. Things like had a workshop where old guys could go and repair things just for the fun of it. The city of Frail, or the town of Frail, reduced the utilization of the hospital emergency rooms in the city by a full third, whereas in the rest of the county of Somerset, they continued to increase. A very simple, straightforward thing that most communities could do very easily by just communicating what's available. Kingston has a lot of things available that are very busy. I think with a little better coordination, we could do really well. And then places like the senior center, for example, would meet a high degree of social needs. There is a problem with the lifestyle need, as Donna said. I think we're turning into a nation of couch potatoes, young and old, and that's not good. So how we fix that is, Catherine, I think maybe your physiotherapy colleagues have got to get off their backsides and make people a little more active. And the same is true for dementia lifestyle needs. Speaking of John Muscadere, and Don referred to this before, the Canadian Frailty Network has invented what I think is a wonderful acronym, AVOID, which the words are, the first word A is activity, V is vaccination, I is the integration with other people, and D is diet. And there is pretty good evidence that's available through the frailty site that, well, you're not going to absolutely prevent dementia and frailty. You will in some, but you certainly delay its onset and delay its severity. So when our questioners would say, well, when people get to be demented and very frail, they'll have to go into residence. And in fact, that's true. But if we can delay their going into long-term care residence and for any period of time, and to reduce the severity of the problem, we've really done a pretty good number. So maybe I'll just stop there and be prepared to answer any questions you may have.
Thank you both. You've covered an enormous amount of ground. You know, I'm always struck by the stark funding contrasts in Canada, particularly around home care. And you know, what really came to mind, Dr. Sinclair, when you're talking, you said it's not home when we think about long-term care, and people need to believe they're at home. There's a lot of comments in the chat already, and so I encourage people, if they want to pose questions there. There's also lots of different links to resources that you both have mentioned. I'm going to pull one question from the chat right now. It's to Don. I heard your comments to Bloomberg this morning on this report. Our government's underutilized regulatory role in keeping the private sector accountable. Can you comment on regulatory directions in aging in place discussion?
Very happy to see that question appear, because regulation is the forgotten arm of public policy. Just to go a little bit deeper in background, I found it fascinating. I'm in a school of public policy that has no courses dedicated to regulation. And in fact, it's only covered in a couple of hours in one of my courses. And yet I figure well over half of civil servants spend the vast majority of their time on regulatory matters. There's not that many sitting in their office designing sophisticated social policies. They're in the regulatory. And this, it's the part of the debate that's missing right now. We have an attitude, I hear it all the time, in this aging, and particularly long-term care, public good, private bad. And there's a middle road in there. Governments, through their regulatory powers, can basically affect whatever outcome they want. It is the bluntest but the most powerful of all weapons. You can try through policy and legislation to provide incentives and disincentives, but you're trying to affect behavior at the margin. In regulation, you just say, this is going to be the outcome, end of sentence. And the private sector has to decide if they want to incur the cost or the inconvenience or whatever it may be to deliver that, but they have to deliver it. But of course, there's two requirements behind that. The first being that you have to have sensibly designed regulations, and I think there's not been a lot of attention paid to that. And secondly, if you do have regulations, you have to enforce them, and we know that they've not been enforced as well. So I don't want to wade in. I certainly don't want to venture opinion on what the share should be in public and private. My point is trying to point out, let's not be naive here. We're not going to actually lower the cost by going to the public sector. And in fact, the wages, including benefits, would likely be a lot higher for the public sector, and the cost could indeed be up. And you're not necessarily going to get different results than you could through smart use of regulation. I just think, regardless of what the feelings are very hot in anything to do with health and healthcare, public versus private. So it's a dangerous ground to venture into. But we have to explore the possibility of using the regulatory arm properly designed and properly enforced to get the kind of results that people are seeking.
Mm-hmm. Thank you for that. Dr. Sinclair, I don't know, do you have any other sort of thoughts on regulatory role?
Well, that's more Don's bailiwick than mine, but I get very concerned about the concept that we would not have competition, whether from the private sector or the public sector. Competition is the way to create beneficial change. And if everything were to be under the public service, we would not get much change in that. That we're well aware of that. So I would be I agree with Don and Charlie. There are certain policy objectives that should be uniform across the perhaps the country, certainly a province. And there are many, but who delivers it and how are those things are met needs to be the result of everybody in every corner of it trying to do a little better. And in the absence of competition, that drive to do better won't occur.
Mm-hmm. Those are great points. I'm going to open it up to if anyone has any comments or questions. Marianne.
Thank you, Catherine, and thank you, Don and Duncan, for your talk. I have a couple of comments rather than questions, if I may be so indulged. Duncan, your comment about the From project, I have the Abel and Clark book right here in front of me because there is a group in Kingston trying to establish Kingston as a compassionate community against the model of From England. And they're working with the Frailty Network. They're hoping to work with Department of Family Medicine at Queen's and with the faith communities in Kingston. And yeah, so, you know, watch this space for more news about them. The other one I wanted to comment.
Are they working with the senior center?
Yes, very much.
Good, good.
Yes. And palliative care as well, and you know, bereaved families and so on. The other comment I wanted to make was about your contrast between care and support, and this has been an issue for the disability community for ages. They also don't like the notion of care and the idea of having to surrender your will and give yourself over to a caregiver, and prefer the terms service or support, and they're used, you know, service to refer to more formal supports and support to refer to more informal supports. So yes, there's a long legacy of not caring for that word.
Thank you very much, Marianne. I'm just going to.
I wonder if I could just add an observation on that. It just makes me think of another aspect of this discussion that is coming up. And there were people expressing we don't have national leadership, we don't have national standards. And my counter to that is, it's like, as a corollary to Duncan's point about the competition, there actually are benefits of our destructured federal fiscalism structure, because people can experiment and look at what works and what doesn't work. And if you get a national standard, it will probably be to the lowest common denominator. Whereas if you did have communities such as Kingston doing really interesting things and they work, you can be pretty darn sure they would end up being copied or perhaps even improved across the country. So, you know, you can go both ways, but I think ultimately a lot of the improvements that we need will be led at the community level. And again, I got thinking, again, coming from, I'm not in the medical direction, but I'm also not in Kingston. So I'm coming and looking at this from a bit of a distance. But Kingston Plus seems to have all the ingredients to really be an interesting leader in this. I mean, first of all, it's an older than average population. It's one that's had some of its industrial bases hit pretty hard. So it's kind of looking for something different, and this fits it. A tremendous benefit from having Queen's. And the interesting thing for me looking at the role from the Queen's University is because I'm used to dealing with academics, or pure academics, and they're pure into theory, and they're not much involved in public policy issues, and they're definitely not involved in communities. And what I find is the unique aspect of the people who are involved in Queen's health sciences is most of them are practitioners themselves, or most of them deeply embedded in the community. And that's a wonderful asset that could help Kingston be a leader across the country in this field, I think.
Those are excellent points. We've often talked about Kingston as something like a living lab. And I think there's so much integration in Kingston between the researchers and the community. You know, and the comments about from care to support really are about transforming how we view aging and really function and disability at the fundamental root of those terms. David Walker has a comment, and I'm just going to bring it up. I don't know, David, if you want to speak to it, or I can read it out.
Well, it's my usual rant that with long-term care is seemingly the Canadian default for the care of the elderly. When they reach the stage they can't tie their shoelaces, will never meet the capacity required to satisfy what we seem to think are the criteria now for long-term care, and those need to be changed in the directions we've been talking about, and Don and Duncan have identified so well yet again. I mean, the practical issue is, of course, that those folks end up backed up into acute care hospitals, and we're seeing that now because the capacity in long-term care has actually shrunk, of course, due to COVID. Notwithstanding the poor souls who've died, the reduction in bed capacity has been an issue. So one hopes that we can use this as an incentive. It hasn't worked before. Government seem inured to this status quo. Perhaps the advent of Ontario health teams, and I agree with what has been said about Queens and this community and the ability to engineer those who are on the ground as well as involved in the academic exercise and integrating many of the services that should allow people to stay home comfortably longer with the supports they need. And I hope that will become one of the criteria for the measurement of success of Ontario health teams.
Right.
Every time somebody has a question or a comment, it makes me think of something else that's been on my mind. As along the lines of what David Walker is talking about, you know, when we're thinking about 2041 and trying to do these projections, you imagine what the world would like. And it said one of them is the status quo, in which there's over 500,000 long-term care beds. I would attach about a 0.001% probability that's going to happen. I don't think anybody's going to build that capacity, and probably they shouldn't. The second possibility would be this continuum of housing needs and other services, from greater support in the home to community living in the Kingston area. Again, the examples make many more oases, what you're talking about, Compassion at Kingston. One hopes that, but we're off to a very slow start on that on a very low level. So maybe that's not going to flow. And then you sort of wonder, then it comes back to, so then what does it look like? Because the one thing you can't do anything about is these 4.2 million more seniors. They're coming, whether we're going to prepare for them or not. And so first it becomes, they will become the responsibility of whoever is connected with them, daughters and sons and the likes. But of course, some are not in a position to have that kind of support. And then I guess it comes as David Walker's scenario. If there's 13% alternative level care patients in a hospital at the moment, I guess we permanently go to 20%, and that's not good for them. And that's, if anybody's concerned about public cost, that's, you're probably talking about $1,000 plus per day, whereas you could do a lot of the home care for $40 to $100 a day. So it's, I just worry. And then, you know, I'll come back to one of the other most common questions we had is, why do you think, if nothing's been done about this for decades, that anything will be done now? And I think in part it comes back to political power. I was responsible as a civil servant to try to convince Canadian seniors to accept income testing in the old age security in 1995. And I learned an awful lot about dealing with seniors. My main lesson is you don't tick them off. Man, can they organize. Like overnight, the Canadian Association of Retired People came with an initial singular purpose of fighting that thing. They, every time members of parliament went back to their ridings, they just surrounded them. They're educated, they got time, they actually write letters, and they're a very powerful lobby group. And I think they will be exercising their voice, because at the moment, if you think about the ones that are just crossing, again, me as the prototypical baby boomer, just crossing that 65. Many are well into looking after their own parents and struggling with that. And many are starting to think about their own futures not looking very good. So I think they will start to exercise even more considerable voice than they have in the past. And maybe that gives some kind of hope.
Mm-hmm. There's some great comments in the chat here. I'm just picking up something that Helen Cooper just mentioned. She said, I suggest we have to better define the parameters for the provision of home care. You know, if we think we're really shifting in the community, what we need to think about home care. Any comments on thinking about home care and or gross lack of spending in that whole realm?
Well, I would suggest that a little expedition by some of the powers that be to go to Denmark and see what's there on the ground. Which, well, you've been there. You've been able to see what really goes on in an environment in which, A, the municipality is deeply involved, i.e. local initiative. Our municipalities are not involved from a taxation point of view, whereas they are over there, but it's not entirely the tax base they're dependent upon in Denmark, not solely the property tax base. So local control, which we don't have here. We've got a lot of control that originates in the Hepburn block in Toronto, and what's going to work in downtown Toronto is not necessarily going to work in Kingston, much less in Northern Ontario. So I would, the first thing I would do, I must say, is encourage some exploration of what really is working elsewhere, including in Frome.
Well, and you bring up Denmark, Dr. Sinclair, and they again not only think about home care, but are looking upstream and thinking about models of enablement, prevention. So it's not about just providing support after you need it, but it's providing, you speak about getting people active, it's really thinking about that, and what's the government role, and how do we get more funds and direction? We talk about it, but it hasn't really been done.
Absolutely. Thank you.
Sorry, David
for
Townsend.
reminding me of that little phrase, upstream. It's the way, it's the place to work.
David Townsend, you had your hand up.
Sure. Duncan knows that I couldn't participate and not open up and say something. I'm the executive director with Southern Frontenac Community Services. So we're very much on the ground trying to deal with seniors. One of the issues that we're constantly facing is that we're funded by the Southeast LHIN. We're given quotas to reach. We surpass all those quotas. We have to fundraise in the community, but more importantly, we are a user-pays system at the community support service level. So seniors coming to us have to pay for their rides to medical appointments. They're all subsidized, or their Meals on Wheels, or their foot care, or their adult day program. And we will honestly find that at least 1 in 3 seniors who will say to us, I'm not going to take your services because it should be free, like healthcare is. And it's a huge issue at trying to convince folks that if they take advantage of these, their health will stay better longer and they'll be able to stay in their home longer. But it's a funding inequality in our current healthcare. I'm not going to use the word system because Duncan would probably yell at me. But it is something that we need to change, how seniors and people are getting the supports they need.
Right on. Couldn't agree more, David.
That is a good point.
Yeah. Although the issue is that whereas hospitals and physician services have long been regarded as free, when Medicare began, the envelope was much bigger. It covered many more things than just physician and hospital-based services. And then the envelope shrunk, and the obligation of people to pay some of the cost if they could, which was in the original Douglas philosophy, that disappeared too. There are many of us who could still afford the premium that Tommy Douglas opposed. There are people who couldn't, and their services should be, quote, free.
Those are
and then there'd be more of it. Broader spectrum.
Right. I'm going to pull on a few other questions that are in the chat here. This is from Vince DePaul, and he's asking, is it realistic to rely on governments to fund novel solutions related to aging in place? Or should we be looking to private not-for-profits and charitable organizations for support of this new long-term support model?
Well, I would definitely agree with that. I guess starting from the top is I would never look for the federal government to take a lead in this. They may well cough up some of the money, but you've already seen the phenomenal controversy of that. And actually, I don't blame the provinces in their position. the federal government is keeping a very tight lid on the growth of the Canada Health Transfer, but they're saying we got money for boutiques, home care and long-term care, but only if you do it the way we're happy. And they're demanding provinces show them their spending plans on long-term care. Well, that doesn't quite jive with the way the Constitution was written. So I don't think they're doing it. We've had a long history of none of the provinces been very good about directing this. I mean, as David Townsend was just basically referring to the Southeast LHIN, I mean, you get your allocation from them, but it was just the province that kind of sent them out with a lot of sophistication at that central level. I think municipalities will, in addition to the list that was presented, I think municipalities can and probably will likely play a role. But as Duncan said, we have this oddity that we increasingly have municipalities as the action of policy, but they're the most limited in their fiscal resources. They're almost totally dependent upon resources transfers from the other levels of government, just with property taxes essentially on top of that. So there is a bit of a collision course between their responsibilities and needs and their potential funding that would have to be sorted out. But then my own view is, like, let's not take the private sector out of that, because the private sector, if it does combine with community resources, not just the municipalities, the charities, the Compassionate Kingston that was mentioned and the like, we do that, I think that will happen. And if I look at my crystal ball, how this will unfold to 2041, we will start off with a fairly smallish number of community-led initiatives that will seem to work quite well. And then there will be some documentation of best practices, and slowly that will spread. But it will not be led by even the provinces, and it definitely will not be led by the federal government.
Those are good comments, and I'm picking up on, and again, it's that slow spread. And I know they often talk about Canada being a country of pilots. And so, you know, it's thinking about how to take that data from those community-led initiatives, right, and have a swell of support. You know, at one point, it's hard to know how to expand those. I'm just looking, somebody, Petra has a comment. So she talks about staffing shortages, just to go back to Don, when you were speaking about, in long-term care. Just 5 years ago, families would be able to have a PSW support in the home for home care with overnight respite. Today, there are rural communities in the Southeast LHIN that do not even have an hour a week for personal hygiene support. Families are told to pay for PSWs at $20 to $40 an hour, and just not the reality for people. I don't know if there's any comments on just even availability, whether the government could pay for it or not.
I find this whole issue of labor shortages a fascinating one. I'm deeply embedded in it. I chaired a panel on labor market information way back in 2008. The good thing about it is the 51 recommendations I made, 49 of them are still available to be implemented, because only 2 of the 51 were ever acted upon. So we have a really mess. But one of the ones that was acted upon is we do have a job vacancy survey. And every time you see the headlines of some job that is where they can't fill them, you find out the job vacancy isn't particularly serious. The one that's consistently the tightest labor market in Canada is in healthcare. And I think one of the reasons why you don't get attention from it is a variety of different healthcare providers, not just one. And there's no national voice that speaks on behalf of all of them. They speak for their own occupations, and they speak typically within their own geographical regions. So you don't tend to get that. Whereas you do in the IT industry, for example, there's a national association, and they will scream constantly and always looking for government. You know, I guess I'm just the naive economist. Economics is only based upon supply and demand. If you can't get the supply, you need to raise the price. And we have wanted to pay personal care workers and others associated in this field barely above minimum wage, and we have not wanted to afford any money to have them trained or certified and the like, and to some degree get what you want. There's probably limits to that. There's be competition against other sectors, but unambiguously we're going to spend more. And as I said, we have 1/3 fewer workers in long-term care and personal worker than the average of the OECD. So we've got to realize we're under, but we don't pay very much, and we're going to have to pay more. That's part of that. how are we going to take 1.3% of the country's resources and jump that all up to 4.2%? A lot of people are going to end up paying a lot of more of it, and more and better qualified and better paid workers is going to be part of it.
Mm-hmm. Yeah,
And
that's
if I can just add one other thing, is the addition not only of the pay and of the training, but of the respect. PSWs really are at the bottom end of the cascade of respect among the health providers. And certainly when my wife was dying, she looked forward, I think, with greater pleasure at the arrival of PSWs than she did any other provider.
they're the backbone, really, of thinking about supporting people in the community.
Absolutely.
And yeah, I'm gonna turn it over if people have one last comment. It's very close to 1 o'clock, and I just want to reach out to everyone who's on the call right now if they have any one final comment they'd like to add. Well, there's been a lot of great chat. So what we're going to do is I'll download the chat too with a lot of links to different resources that people have been referring to throughout the conversation. I just want to say an enormous thank you. We have covered a broad range of topics, anywhere from regulation, staffing, alternative houses, how we conceptualize aging, in a really thoughtful conversation. And I so appreciate winding up 2020 on this conversation here, and hopefully we can continue talking about aging and policies and health services related to that. So I just wanted to say thank you to you both, and hope you have a wonderful holiday season. Thank you, everybody.
Thank you. You too.
Here, bye.
Bye.
Thanks, everybody.
Bye-bye.